Alright, beginning with Chapter 59, Care of Patients with Problems of the Biliary System and Pancreas. We'll begin with cholecystitis. Cholecystitis is an inflammation of the gallbladder. There are two different types of cholecystitis. We have calculous and acalculous. Calculous is when there's chemical irritation and inflammation from gallstones or cholelithiasis. Now, trapped bile is reabsorbed and acts as a chemical irritant to the gallbladder wall. With this type of cholecystitis, ischemia and infection occur. Now, peritonitis. Peritonitis is infection of the peritoneum, and that can happen if perforation occurs. And the perforation is a large perforation of leaking contents. Okay. Now, gallstones are classified as either cholesterol or pigment stones. Cholesterol calculi, those are the most common type of gallstones. Now, suppurative cholangitis. With suppurative cholangitis, that can result from bacteria, and it is life-threatening. It's when pus accumulates in the ductal system. Now, acalculous cholecystitis, that's when there's inflammation of the gallbladder, but no gallstones, associated with biliary stasis. Now, with this, pancreatic enzymes reflux into the gallbladder, and it causes inflammation. The sphincter of Oddi or Oddi, the dysfunction can occur, and most of the patients with this type of cholecystitis, they're either going to be suffering from hypovolemia, some sort of organ failure, sepsis, or burns. Okay. Chronic cholecystitis, that's when there's a chronic inflammation, and calculi are typically present when there's a chronic inflammation. Now, bile obstruction leads to jaundice. Jaundice is that yellow color of the skin and mucous membranes, and icterus is when we have a yellow color of the sclera. Now, it's commonly seen in those with the chronic form of cholecystitis. Jaundice and cholecystitis can be caused by direct liver involvement. With obstructive jaundice, the bile is blocked. Okay. Now, the accumulation of the bile salts, that can lead to itching or pruritus, or a burning sensation. Urobilinogen is the color that makes the feces the brown color. And urobilinogen, whenever we have the large intestine and the bile flow is blocked, that results in the clay-colored stools. Cholecystitis is familial and genetic, as well as can be caused by nutrition habits, and sedentary lifestyles. Okay, risk factors for developing gallstones are obesity, type 2 diabetes, dyslipidemia, and insulin resistance. Independent risk factors are age, female gender, and family history. Crohn's disease is also a risk factor for gallstones. American Indian and Mexican American, those are the highest population of the frequency of gallstones. On page 1215, there's table 59.1. It says risk factors for cholecystitis. We have hormone replacement therapy, aging, women, Crohn's disease, sickle cell disease, pregnancy, genetic factors. Typically, the patients that are most at risk for gallbladders are those that are female and are about 40 years of age. And sometimes the amount of fat we have plays a role in that as well. Now, diets that are high in fat, high in calories, low in fiber, and high in refined white carbohydrates, those typically place the patients at a higher risk for developing gallstones. We want to note whenever food is eaten if the patient experiences gas, any indigestion, any belching, or any nausea, vomiting, or abdominal pain. Now, biliary colic is pain that's from an obstruction of the cystic duct of our gallbladder. And with biliary colic, tissue spasms occur because they're trying to move the stone or more than one stone. Okay. Now, sedentary lifestyle, rapid weight loss, prolonged fasting, and pregnancy are all risk factors for developing gallstones. If the patient's on any type of oral contraceptive or birth control pill, that can be a risk factor for gallbladder or gallstones. When we're assessing this patient, we want to look for any rebound tenderness, which is known as Bloomberg's sign. And remember, we as nurses, we only palpate very lightly. We do not perform deep palpation. Late symptoms for chronic cholecystitis are typically jaundice, clay-colored stools, and dark urine. And patients sometimes don't seek treatment until those symptoms are apparent. Now, steatorrhea or fatty stools, those occur because fat absorption is decreased, and the fat absorption is decreased because of a lack of bile. Okay, with these patients, they're probably going to have an elevated temperature, 99 to 102 degrees. They're going to experience tachycardia and dehydration. Now, calcified gallstones can be viewed with just an abdominal x-ray. Ultrasonography of our right upper quadrant is the best for the diagnosis. HIDA scans can be performed as well. HIDA scans help to visualize the biliary system as a whole. Now, ERCP and MRCP can be done. With ERCP and MRCP, the patient is given oral or IV contrast. Whenever our patient does receive any type of IV contrast, we want to make sure that they don't have any history of allergies. And it's important to remember that gadolinium, it decreases the risk for any type of allergic response because it does not contain iodine. With acute biliary pain, these patients are going to need pain medication. Now, all opioids will cause some degree of the spasm of the sphincter of Oddi. Okay. Now, NSAIDs may be used for those with mild pain. Gallstone stabilizing agents can be given orally. ESWL is a procedure, it's shockwave lithotripsy, and that can be done to break up the gallstones, and they're passed through the digestive system. If that doesn't work, we can resort to surgical management and cholecystectomy. Cholecystectomy can be performed laparoscopically or as an open approach. We want to make sure that this patient's aware of what to expect after surgery, that there will be pain. We want to make sure that they're able to perform deep breathing exercises and understand why they should perform deep breathing exercises. We want to make sure that these patients know how to assess their incision and look for any signs of infection. And we also want these patients to perform leg exercises to prevent any blood clots. Now, a large intake of fatty foods for these patients can result in abdominal pain and diarrhea. And that could be from mild post-cholecystectomy syndrome. Patients will want to introduce foods that are high in fat one at a time to decide which foods are best tolerated. Okay, These patients want to eat nutritious meals, and they want to avoid an excessive intake of fatty foods, especially any type of fast foods, fried foods, or buttered foods. We want to remind that patient to report any abdominal or epigastric pain that occurs with vomiting or diarrhea. And it can occur several weeks to months after surgery, okay? That's also an indicator of post-cholecystectomy syndrome. If you look at table 59.2 on page 1218, there is a list of biliary versus non-biliary causes of post-cholecystectomy syndrome. In the next audio, I will begin with acute pancreatitis.